Right, good morning everybody. Goeiemorgen vir al die Stellenbosse mense. I do not speak any other South African languages. We could do some foreign languages because we have a number of foreign people here today. So welcome to everyone in the room here at STIAS, which is the Stellenbosch Institute for Advanced Studies. Lovely to have all of you here. I think it's quite a historical event. And many of you may not know that we're also saying hello to people on live stream. So this is being live streamed. So welcome also to anyone who's watching this on live streaming. It was Alexis and Max's idea to do the live streaming, so I'm very happy that we can do it. I'm Prof. Petrus de Vries. I've met a number of you. I'm the principal investigator of a particular project that you're going to hear about today. But I'm also based at the University of Cape Town, and when we decided to bring a team of international researchers to South Africa, the first thing we said was, let's not just have a conversation with ourselves, let's make sure that we can have a conversation with people in our community. Because we know that there are many, many people who live with TSC in South Africa, in many African countries, who have a huge need for knowledge, for support, for information, etc. So that's the main purpose of today. It's really just for us. That's why we call it an impact event, to try to have some impact in the communities that we want to serve. In the room today, we have members of the TAND Consortium. So they are we're about 25 people from 10 different countries around the world. You're going to hear from some of them today. I'm not going to get everyone to introduce themselves. That'll take the whole introduction. Maybe you can just wave at everyone else. Consortium members, just wave at the rest. There we go. Now you know if you're sitting next to them. Consortium members are researchers, doctors, people who live with TSC, family members of people who live with TSC, people who are part of international organizations for TSC. So we're a real mix of people who are here as part of the consortium. In the room, we also have family members, people who have TSC, doctors. I think there's a bunch of educationalists. We have educational psychologists and teachers, and people who support individuals who live with TSC in South Africa. So it's great for us to have such a mix of people with us today. You will see on the program, we're going to run through 2 hours of work and talking in this room. Then we're going to have a tea break, and after that we're going to move to the room next door for roundtable discussions. And when we start the roundtable discussions, I'll tell you how that's going to work. And then at the end of the day, we're going to come back in here just for a wrap-up before lunch. So that's our plan for the morning. Before we start the kind of official presentations, I want to invite Professor Anna Janssen, who is my partner in crime, who's the co-principal investigator. She's from the University of Antwerp now, but the project started when she was still at the Vrije University in Brussels. So Anne, 2 words from you as well.
So good morning also from my side. I'm very grateful that I can welcome you all, especially in the company of all the people from the TAND Consortium. It felt very special yesterday when everybody was arriving and we could meet again, connect again, be together. I also am very grateful that we can meet with a number of families here. And I very much look forward to the second half of the morning where we will have the roundtable discussions. Because we would not have been here if it were not from the discussions we had earlier throughout our entire journey with families and with the community. Because the work that we've done so far has really been inspired and driven, and our motivation is really derived from the discussions that we have with the families. So I'm very grateful that we had the opportunity to connect with you also this morning. So welcome from my side.
Great. Thank you, Anne. The one thing I forgot to say, apologies for those online, is the bathrooms are just over there. So you have to go out the doors and behind us if you need to go. If you need to sneak out, I would suggest sneak out that side, unless you want to be on the movie, which is on this side. That's also fine. You're welcome to be on the movie. And I think that's the main housekeeping job I was meant to do. We're going to dim the light slightly for the presentations. So it was either very bright like this and then you can't see the screen, or very dark and everyone will fall asleep. So we've gone for something in the middle. So I hope the in the middle is okay. I'll check in with you as we get going. So we're now going to get ready, I think, for our first presentation of the day. And as Anna said, because our philosophy in the TSC community is families and people with TSC first, we always like to ask somebody to tell a personal story about TSC. So it's lovely for us to have Alexis Menard, who's come all the way from Joburg to talk to you a bit about her own story and her personal journey with TSC. Alexis, David will help you set up, we'll dim the lights, and the floor is yours. I'm going to be the timekeep for all speakers, so I will, if I start to come and stand next to you and wave, that will be your clue, all right? Alexis, David will set you up.
I don't know how to control the mic, but hi guys, I'm Alexis Menard, and today I'll be sharing a very short story about my life with TSC. I was diagnosed with epilepsy at 9 months, scaring the living daylights out of my parents. It's interesting because I started showing signs and symptoms of epileptic attacks during everyday activities, and this really startled my mom. And being a 1994 kid, surprise, TSC is associated with a lot of stereotypes, but my parents are not easily discouraged, and so it was a shock, but a motivation to start doing research on TSC. Finding doctors during this time was exceptionally difficult. As I said, there were a lot of stereotypes. So I was officially diagnosed with TSC when I was 2 years old, and the doctor very politely left my parents a voice message on their answering machine explaining how my life was ruined. I wasn't going to manage school, I wasn't going to be independent, I was never going to be able to dress myself, and so on and so forth. And this really shocked my family to no end. But nonetheless, we face the future bravely, no matter how unsure we are. And yeah, so on it goes. The second doctor that my mother decided to approach was an academic professor who threw quite a few of academic vocabulary at them. And it makes her useless if you're a civilized person living a normal life, not understanding the vocabulary. Okay, great. You know, it just adds to the fear, really. However, like I said, my parents do not easily believe in stereotypes, so my mom started doing research. We started doing homeschooling, especially after some severe bullying attacks. And when I say severe, I mean going home black and blue because people didn't like the way I look or what I ate or the medicine that I was on, and so on and so forth. My mom is a very strong believer in mathematics, reading and writing, and in between all of that, you get to learn other things like geography. You'd read a story and you learn where it takes place and what time era it was, and so that was also very fun, and my brothers enjoy it as well. I have two exceptionally healthy, so this slide is just when we were diagnosed and how we adapt. I have two very healthy brothers. One is 3 years younger, the other one is 10 years younger, as you can see in the pictures. This has been one of the most challenging things I've managed to live with, is why am I different? Why do I have a red face? Why am I sick? But my baby brothers, my younger brothers are okay. What's the connection? So it turns out I had a mutation during conception. My brothers had no mutation during conception, so they are fine. But we have a very open and honest, age-appropriate, I might just add, relationship when it comes to my TSC. So they come with me to doctors, they come with me to scans, they come with me to the hospital, and we turn it into a field trip for school. Surprise, we're doing an EEG scan today. What does EEG stand for? Oh, okay. Let's go talk to doctors. Doctors like to chat, by the way. If you ask them questions, they just talk. Like, so it was a lot of fun to go on these trips. And you know what? One thing my parents do not tolerate, and I'm sure a lot of you can associate this, is the victim mentality. Woe is me, I'm sick, I can't participate, or I don't want to participate, or any such excuses are not tolerated in my home. And I'm so grateful for this because I am 28 years old and I do not hide behind my condition for any circumstances. There are decisions I have to make. I can't go on roller coasters. That would probably send me into a seizure, you know. Stimulus or bungee jumping. I choose not to drink. It's not safe. You know, like these sort of behaviors are exceptionally important. So to wrap up just quickly, today I am 28 years old. Today I have a matric certificate. I have a teaching diploma. I am busy studying my second degree. I have been married for 7 years, and life has just been interesting. It has been challenging, but it has been fun. And I'm a very strong believer in the quote, oh, sorry, let me just find it for you. Life without strife is life without color. Life without difficulties has no interest. And I am also a very strong believer in, if at first you don't succeed at something, try again, and you will accomplish eventually. So yeah, thank you. That's me.
Thank you, Alexis, for a beautiful start, for setting the atmosphere, setting the scene for our meeting today. We're delighted. And you're here all day, so yes. Alexis is always happy to chat to anybody. Right, Alexis? Good. So we need to start with a personal story. And from the personal story, it's also helpful to make sure that we have a sense of the basic information, the basic facts, and the evidence base, the kind of current information and recommendations by experts in the field. And so it's really nice for me to introduce to you our next speaker, who is Dr. Darcy Kruger. Darcy runs a tiny little tuberous sclerosis clinic that has about 1,000 people with TSC or thereabouts in Cincinnati, in Ohio, in the USA. And Darcy and his colleagues, predecessors, Dr. David France, and they have a big TSC team. They've done some amazing work over the last 20, 30 years. Firstly, to find support for people with TSC, to do good research, to find drug treatments that we can use in TSC. And Darcy has also led the development of the international clinical recommendations that we are proposing everyone in the world should try to use. So Darcy's had a few lovely days of being on holiday in the bush, so he's fresh and ready to answer all your questions. But first we're going to give him about half an hour just to put us all on the same page about TSC, clinical challenges for TSC, and recommendations for how to work with those. Darcy, please take the floor.
Thank you, and it's wonderful to be here today. I echo what Anna and Petrus have said. It's so wonderful to be back together as our TSC doctors and families and parents and experts, but also to be with you. And so as Dr. DeVries mentioned, my task today is to cover all of TSC in 30 minutes, which is an impossible task. So I will refer to our published guidelines. And in the roundtable sessions, if you don't already know where to find those, find any of us, and we know how to point you to those on the internet so you can find those documents, because we won't have time to cover everything. Also, I always struggle with these type of meetings because some of you have been dealing with TSC for 28 years, and you're somewhat expert. And even myself, I finished medical school in 2002. And I had heard of tuberous sclerosis in a textbook. I had never seen a patient with tuberous sclerosis. And then I started my training as a neurologist, and I started meeting a couple patients with tuberous sclerosis, but by no means was an expert. So apologies if some of this material I covered today is very basic, but remember, all of us started out knowing nothing about tuberous sclerosis, and I know we're recording this for families and other individuals that we continue to help along in their journey, just like each of us has experienced. So I'll give a brief overview of tuberous sclerosis and a brief about the mechanisms, not so much that this conference is focused on those mechanistic treatments, but as we have learned to understand tuberous sclerosis, understanding those mechanisms has played an important role of how we are approaching treatments now and in the future. And then I'll talk about the guidelines. So, as you heard, it is a genetic condition. It is considered rare, but it's not that rare. There's probably 1 million, maybe 2 million people individually around the world who have tuberous sclerosis, but when you think of the world having 7, 8, 9 billion people, it means that there's not a whole lot. And it means that doctors sometimes have seen a few cases, and sometimes doctors have never seen a previous case of this disorder. But it's common enough that it brings us together, and there's some features that need attention medically and socially and mentally and in our overall health. It's variable in its expression, meaning really no two people with tuberous sclerosis are exactly the same. And that variability has a couple different ways that we have to deal with. First of all, although it can affect every part of the body, the human body, not everybody has every organ or tissue in their body affected by tuberous sclerosis. So some people may have largely manifestations that affect how the brain works or looks. Some of them may have manifestations that affect how the skin works or looks, the heart, the lungs, the kidneys. But there are plenty of people who only maybe have brain stuff that really afflicts them in any major way, or only have skin manifestations that afflict them in a major way. Other individuals may have heart or cardiac manifestations, but they go away when they're a child and are really not a major concern for them for the remainder of their lives. So because of this distribution of the body, that creates some challenges to us on how we deal with tuberous sclerosis, both in where it affects the body and how severe it affects that part of the body. Another degree of complexity is the timing. I mentioned that some individuals deal with heart issues very early in life as babies, or even before they're born. We can detect in some mothers that it's expecting a child that we say, hey, there's some things on your ultrasound that suggest your baby may have tuberous sclerosis, and we're worried about that baby's heart. But pretty soon, a majority, fortunately, after we assess their hearts after the baby's been born, the majority of them have very safe hearts that last the rest of their lives and don't require any major intervention. A few of them we do have to pay attention to. We worry about the kidneys, sometimes in the first year of life, and sometimes it's more an adolescent issue or it's an adult issue. We worry about the lungs, affecting sometimes women who are adults in tuberous sclerosis. And then the skin manifestations, some of those may be very early detected, and some of those show up much later. But this complexity of sometimes it's a newborn doctor who's making a diagnosis of tuberous sclerosis and deciding what to do. Sometimes it's a cardiologist in the nursery. Sometimes it's the pediatrician or the general family doctor. Sometimes it's an adult doctor who's first encountering a person who might have a tuberous sclerosis diagnosis. So this timing complexity adds to the challenges. Now, we have over the years learned from doctors that have carefully studied tuberous sclerosis of various features that really help us identify somebody who's diagnosed with tuberous sclerosis, and we call these major diagnostic criteria. These are signs that are very highly likely to lead to a diagnosis of tuberous sclerosis, although it's not 100% certain. And so many of these are some of the skin manifestations of the face, of the skin on the trunk usually. We see the white spots, what we call hypopigmented macules. As a child becomes adolescent and or an adult, we often start to find little bumps in the fingernails or the toenails called fibromas. We can see in some patients having benign tumors of the eye or spots in the eye, and that can help us make a diagnosis physically. Many of the other manifestations require us to do testing. MRIs or computed tomography or CT scans or ultrasounds, where we look internally at organs to see if they have tuberous sclerosis signs. In the lungs, we call that lymphangioliomatosis, which is a very difficult word to say. I have had years practicing and I still mess it up, so we often call it LAM because that's much easier. In the kidneys, we can get benign tumors called renal angiomyolipomas, and we used to call those AMLs, and you'll frequently still hear people call them that, but we try to move away from that terminology because there's a cancer diagnosis that also has those letters, and this is not cancer, okay? We can also get cysts in the kidneys. I'll talk about those in a minute. We get tumors in the heart that are benign called rhabdomyomas, and then we can get various scar-like tissues in the brain that are when the brain is forming before the child is born. And these are what we get the name from, tuberous sclerosis. And we call those cortical tubers, but there's also some other abnormalities or scars in the brain, such as radial migration lines that help us make a diagnosis of tuberous sclerosis. And then I'll spend a little more time talking a little bit later about subependymal giant cell astrocytomas or SEGA, which is much easier to say than that long term. So some of these manifestations we can see on an examination, and some of these require tests. We also have other features of tuberous sclerosis that are also common in tuberous sclerosis, but unlike the major criteria, these may or may not be associated with only tuberous sclerosis. So they're helpful for us to confirm a diagnosis of tuberous sclerosis, but we see these frequently in other disorders as well. These can be very tiny confetti-like lesions that look like the hypopigmented macules, except they're really tiny. We call these confetti lesions. We can have little deficits in the tooth enamel, which we call pits. You can get fibromas of the gums. You can get white spots in the back of the eye. You can get common cysts, which we call renal cysts, in the kidneys. You can get polyps in the colon, and this is important to remember because if you don't have tuberous sclerosis and you're diagnosed with polyps, it's very worrisome. That's a precancerous or an early cancerous state that leads to very serious outcomes. But in tuberous sclerosis, these are largely benign, so much less worrisome, and we're able to take a much more cautious and measured approach to their discovery rather than in somebody who perhaps did not have a tuberous sclerosis diagnosis. We can see benign tumors in the liver, in the pancreas. We can see lymphatic collections of fluid in the body. We can see little cysts in the bones, that the bones are as healthy as otherwise, but that they can surprise a doctor if they don't know what they're seeing. Okay, so these are common in tuberous sclerosis, but they may not be only seen in tuberous sclerosis. And the way we make a diagnosis is by either adding up a number of major findings or major findings plus minor findings, or we can now use genetic testing also to give somebody a diagnosis of tuberous sclerosis. So this is how we are today. We still follow these methods for us to say you have tuberous sclerosis, or we say you might or possibly have tuberous sclerosis. And the reason we make that distinction is because if we're not 100% sure, it certainly pushes us more strongly to make sure we do genetic testing to see if we can get a definite answer. Or it may also, if we say that you have possible tuberous sclerosis, maybe we don't have to do all the tests that are recommended for somebody who has a definite diagnosis. It gives the doctors a little more flexibility when there's a possible diagnosis. But it also tells the doctors to not, I have to set my thing every 10 minutes because otherwise I speak too long. But it also, the possible diagnosis tells the doctors not to forget, not to quit thinking about this, because some things may not have shown up yet. And you may be moved into that definite diagnosis at a later date when some of these later parts of TSC start appearing. Or something new shows up, like a bump on the thyroid, or a nodule in the lung, or a polyp in the colon, and somebody says, oh yeah, you have that possible diagnosis of TSC. We may not have to be nearly as worried otherwise. So it helps to always remember that in the back of their mind. Just a little bit about the molecular base of tuberous sclerosis, and this is a very basic, but we have in our bodies a sensor that tells when cells are supposed to grow. It also has important other aspects, like in the brain, it tells cells where to go. It tells them who to talk to each other. And so all these external signals have to be funneled through what I call the central processing unit of the cell. And at one of the key switches for that central processing unit of the cell is called mTOR, a mechanistic target of rapamycin. And the tuberous sclerosis genes, the proteins that those make, are an important regulator of that switch. And when you don't have the gene telling mTOR what to do, it kind of decides to do what it wants, willy-nilly. It decides on its own. And that creates all sorts of problems, and that's why we have the various manifestations we see in tuberous sclerosis. And this was worked out by people before I ever knew much about tuberous sclerosis. There was large consortiums like this one in Europe, one in the United States, working frantically to find these genes. And the consortium in Europe found the first gene, and the consortium in the United States found the second gene. And to this day, those are the two genes that we know cause tuberous sclerosis. But along the lines, there was a whole group of researchers working in the cancer field because they were studying how cells grow, and they found that mTOR was central to telling cells how to grow, and pretty soon the TSC researchers and the cancer researchers figured out they were studying the same thing. And because of that, the cancer people had already studied some medicines, and we had the genes. And so the two got together and they started using these medicines. One's called sirolimus. You may refer to it as rapamycin. And one's called everolimus. And there's a few other medicines that are very similar to these, but these are the two that we've studied in tuberous sclerosis the most. You can see they're very similar. We use both of them in our clinic. Sometimes one is cheaper, sometimes one is easier to obtain. So we use them both frequently in our clinic, reliably. And our clinic and many other researchers around the world contributed to very large clinical studies, starting with just a few patients saying, is it safe? And then we moved on to a few more patients saying, does it work? And then we moved on to even larger studies that involve patients in countries from around the world saying, is it working well enough that we can get governments to approve it and pay for it. And in the United States, we now have 5 approved treatments, and many other countries also have these approved treatments. One is to treat the lung manifestations, one is to treat brain tumors, one is to treat kidney tumors, one is to treat epilepsy that doesn't respond to other medicines, and most recently, we now have a topical treatment to treat the face. All of which these have gone through these large developmental programs over the last 20 years. So I'm going to spend the remainder of my time talking about, well, where does this leave us now with how to diagnose and to monitor and to treat patients who have tuberous sclerosis. All of this work is published. It's freely available online. The TSC Alliance, combined with the journal editors, worked with us to make it so that it was free to everybody across the world without any pay or paywalls. We want it freely accessible. And then Tuberous Sclerosis International and the TSC Alliance also have these links that are posted on their websites for these to be found. We started this process. There had been some early work done in the late 1990s saying, hey, this is how we diagnose tuberous sclerosis. But we met first in 2012 with more than 70 experts in tuberous sclerosis, family members, just like this consortium, researchers, clinicians, and advocacy organizations all got together from, I think it was 12 different groups of body systems of expertise. and put together these recommendations. And then we met again in 2021 to say there's been some new discoveries, can we update those? And we anticipate that sometime in this decade, again, we will meet again because there's exciting work being done in epilepsy, and there's exciting work that's being done in TAND, particularly, that you'll hear about today, that will most definitely need to be integrated into the next update. So let me just talk about some of the things you would find in that guideline. We'll talk about first SAGAs, because this is where a lot of my research happened to start. These are tumors that grow into the brain, about 10 or 15% of individuals with tuberous sclerosis. It almost exclusively, although there are some rare reports of adults having these, suddenly start growing. But typically they grow with a peak onset around age 8 or 9. But I've had babies that were born in the newborn nursery that we scanned their brains, and we found that they were there even when they were born. So it's something that we have to pay attention to, primarily through childhood, but we continue to at least pay attention during adults as well. And over time, it's a benign tumor, so it doesn't metastasize, it's not malignant, but it can grow slowly, and it's deep within the brain to where it can block the flow of fluid that is essential to cover and bathe the brain and cushion the brain. And so if that fluid cannot freely flow, then we have significant complications. It may start with clumsiness or nausea or some headaches, and then it'll progress to some double vision or vision difficulties. But eventually it can become life-threatening or even fatal if not addressed. So although it's benign, it is not something that we can forget or ignore, okay? And these are a couple examples of patients where it was ignored, where the patients had one of these SAGAs and it was not getting checked on regularly by their doctors and through different scans. And what you can see is that the fluid is blocked up. That's the black area in the center of the brain, and it's expanding and pushing on the brain, squeezing the brain and causing all sorts of clinical difficulties. And so in those situations, we used to only have one treatment option. We used to only be able to operate on those. And before we had CAT scans and MRIs, we had to wait till somebody had symptoms saying they were in trouble before we could treat that. That was actually decades ago. Now we use these CAT scans to make sure that we're paying attention to anybody who has one to make sure it's not growing and causing complications so we can treat it before that. And nowadays we have treatment options that don't involve surgery. So what I have here, and I'm not going to have time to go through each of these point by point, but we do recommend that, and we prefer MRIs over CAT scans, but we recognize MRIs sometimes are very difficult to get. They also require sedation because they're longer than a CAT scan. So in many parts of the world, my patients use CAT scans. But they should always get a CAT scan or an MRI when the first diagnosis is made, whether they be 50 years old or whether they be 5 days old. They deserve to have a brain scan so we can see whether or not there's one of these here. And then you have to repeat that every 1 to 3 years. Every 1 year if it's growing. Every 2 or 3 years you can start to space it out if the child is older, particularly if they're able to report their own symptoms. So if they're able to say I'm having headaches or they have skills that would be impaired by clumsiness. This gets really hard in toddlers because toddlers are clumsy anyway, or in patients who have significant autism or intellectual disabilities, then we have to scan them a little more frequently because they can't inform us as reliably that they're having problems. But every 1 to 3 years until they're about 20, 25 years of age, and at that point then we start to lengthen them out. If they've never had a SAGA by the time they're 25, we may never do another scan. Okay. If they had one when they were younger, but it's been really small, we may do one every 5 or 10 years. We certainly would do it, though, in any age, adult, adolescent, or child, if they're not acting as usual. Okay? So a sudden change in their epilepsy control, a sudden change in their behaviors, a sudden change in their developmental progress must prompt an investigation into their brain and some sort of brain scan to make sure that a SAGA is not at the root cause of that. Okay. And then, like I said, treatment, we use mTOR inhibitors nowadays. We used to, at our center, because we were large enough, we used to do 4 or 5 SAGA surgeries a year because we had enough patients that needed that. We've now done maybe 2 SAGA surgeries in the last 10 years. Because now we just treat all of them with mTOR inhibitors, and we've been able to avoid brain surgeries. Okay. So I'm going to skip that. Now we're going to move into a little discussion about epilepsy. So epilepsy is very common in tuberous sclerosis. More than 80 to 90% of patients will have at least one seizure in their lifetime. Most of them will have a seizure, just like we heard this morning, before they are 1 year old, okay? And we can see all different seizure types. The most common two types we see are either epileptic spasms, and in babies we call those infantile spasms. Sometimes you also hear an older term called West syndrome. It's the same thing. It was basically West syndrome contained everybody who had spasms, and then as we started to figure out specific causes, we started breaking them out separately, like tuberous sclerosis. Okay. And we also see focal seizures, and those focal seizures can be just simple zoning out or absence. They can be a simple motor movement without any change in your mental capacity. They can involve confusion or just altered awareness, even to the point where you have secondary generalization to where the whole body is convulsing or shaking. Okay, so all of those start with a focal seizure process. What's important to know is that epilepsy and tuberous sclerosis is very difficult to control. About 2/3 of patients will continue to have seizures even after we've used the medicines available to us to treat those. And so we call that refractory, medically refractory or intractable epilepsy. It doesn't mean that it's totally untreatable. We still can have little victories. We can win battles, okay, while we're still working on winning the war. Okay, so we don't ever give up. We also are very concerned about epilepsy because it has a very closely related cousin that we'll hear much about later today, which is TAND, which is, has many different aspects, but we talk about learning, autism as parts of TAND. That's not all TAND is, which you'll hear today, but it certainly are things that we can define and measure. And what we see here, these are a couple studies that we did in our group in Cincinnati with collaborators, where we showed that if you had epilepsy, you were more likely to have intellectual disabilities, which is what this Mullen Scales of Early Learning measures, and we also were more likely to see signs of autism. Now, this didn't make a diagnosis of autism, but it said you had symptoms that we often see in patients who also have autism diagnoses. Okay. One of the things we've developed and we were able to incorporate into the 2021 update of the guidelines is that we now know EEG can be much more useful to us to predict seizures from when they start, every bit as much they can help us confirm that seizures have started and what type they are. So we used to wait till you had seizures, said, oh, let's do an EEG and see what's happening, okay? And nowadays the recommendation is that if you're born with tuberous sclerosis and we know that you have the diagnosis, now many times we don't. Many times epilepsy is the first discovery of tuberous sclerosis. But if we know ahead of time, we diagnose in the mother or in the baby in the nursery before they had seizures, we now do EEGs in the babies. Every 6 to 8 weeks, just to make sure whether they're started to have seizures before we would have otherwise detected them. This prepares us to start treatment right away. And in some instances, and we may have evidence, we have some early evidence from one study, and we have a confirmation study that we'll be reporting results here in just a few months, is that we know that maybe we can treat the epilepsy before it starts. And that's pretty awesome when we're able to do that. But we have to do these EEGs to be ready for that. We use all the seizure medicines in tuberous sclerosis. Some of them work better than others. Some of them work for specific seizure types. But know that, we continue to use newer medicines, and several of these have actually been specifically studied in tuberous sclerosis, including cannabidiol, which is the derivative of medical marijuana. We obviously have studied epilepsy treatment with everolimus in tuberous sclerosis. We use vigabatrin, particularly for treatment of the epileptic spasms in infants. It's very effective in that population, but it can also be effective for other seizure types in tuberous sclerosis. But we use all these other ones as well in the treatment. From this, we do recognize that this is not easy epilepsy. And so the recommendation is that whenever possible, this needs to be handled by somebody who is expert in epilepsy. Not just a general neurologist, unless that's if you don't have access to an epilepsy specialist, then a general neurologist is what you need. But if you have access to an epilepsy specialist, you must go to see them, because they will know the more broader use of medications available. They will know how to combine them together. Ideally, it's somebody who has other TSC patients, but we know it's a rare disease. Maybe that isn't always available, but that's a recommendation. We also now recommend these EEGs in babies. And then the other important aspects here is that as of right now, the international recommendations do not recommend preemptive treatment. We're waiting for the second confirmatory study to tell us whether that should be universally applied or whether there are specific populations that should maybe receive preemptive treatment. So that information we expect is coming. We do recommend vigabatrin for infantile spasms. There are still individuals around the world that are treated with other seizure medicines for infantile spasms, tuberous sclerosis, and we view that that is a failure. That is not appropriate medical treatment anywhere in the world. If vigabatrin is available, it should be used to treat the seizures in these infants. There are evidence-based studies that show cannabidiol is effective specifically to treat epilepsy and tuberous sclerosis. And the last thing is that we have treatments when the medicines aren't enough. There are epilepsy surgery options by teams that are expert not just in epilepsy surgery generally, but expert in how to use it most effectively in patients with tuberous sclerosis who have tubers in different parts of their brain, sorting out where the seizures are coming from and what the best surgery that should be performed is not a simple task. And so we recommend wherever possible that not only a patient be referred to an epilepsy center that has epilepsy surgery as a treatment option, but ideally it's someone that, a center that has experience in treating tuberous sclerosis specifically in that way. I am not going to spend any time on this, but this is in those guidelines as well. This consortium, in its previous iteration, was instrumental in defining what TAND was and giving us recommendations on how to evaluate it and treat it throughout the lifespan of an individual who is diagnosed with tuberous sclerosis. And that's all I'm going to say because I know we have much more information coming later. But it's in the same document. I'm going to spend less time on some of the other manifestations, not because they're any less important, but just because we're focused mainly on the intellectual aspects and the developmental aspects at this conference today. But in the kidney, I mentioned we have angiolipomas that are benign tumors that grow in and on the kidney. And eventually, these can become problematic in two ways. They can affect the kidney function itself, the filtration responsibilities that the kidney has, the blood pressure regulation responsibilities the kidney has, but they also have imperfect blood vessels that are feeding them. And those blood vessels have weak walls, and sometimes you can get aneurysms, particularly if the angiolipoma gets very large. And so the kidney doctors are responsible for monitoring this and determining whether your blood pressure needs better control, whether your filtration is starting to get endangered, and also whether these are getting large enough where the blood vessels are becoming a concern and that they can cause complications. We also can get what's called polycystic kidney disease. These are common cysts. I've seen these in children as young as 1 or 2 years of age, and they slowly can accumulate through the lifespan of an individual, and they can get quite significant. They're benign in and of themselves, but if they replace enough of the kidney, the normal kidney, then the kidney can't do its normal jobs. And so again, a kidney doctor will keep track of these for us. There is one special condition, happens in about 1 to 3% of patients who have a tuberous sclerosis diagnosis, where they can have a different type of cyst involvement of the kidneys. And these are what we call polycystic kidney disease, to where the cysts rapidly take over the entire kidney. These often show up within a child who's only 1 or 2 years of age. And by the time that they are, 4, 5, 6 years of age, their kidneys can look like this, where you can't see the normal tissue anymore. Blood pressure becomes very difficult or essential to have ideal management in these patients. Their kidney function also significantly can be injured as well. And many of these patients will go on to require kidney transplants, sometime probably in their childhood or adolescent years. Like I said, it's a relatively rare, low number of TSC individuals who have this form of cystic disease, but again, it's the reason why we have kidney specialists that have paid attention to tuberous sclerosis from the beginning, because this is an important part of management. This happens because one of the genes sits right next to a gene that is important for how cysts are formed in the kidneys, and when sometimes the TSC gene isn't the only gene that got affected by the diagnosis. Sometimes it's both genes together. So we do recommend, just like in the brain, keeping track of STIAS, that you do need to keep monitoring the kidneys throughout the entire lifespan of anybody with tuberous sclerosis, starting with diagnosis. And just like in the brain, every 1 to 3 years, take a little peek at the kidneys. Again, MRI is the preferred method because we can see so many more things. We can see oftentimes the blood vessels very clearly. We can see the nature of what those tumors are, and many people will confuse them with, I've lost track of time, thank you. Many times, they will be confused with cancerous tumors, which these are not. Okay, and so we've had patients over the years be seen by doctors who are not familiar with tuberous sclerosis, who are recommended to have a kidney removed, either partially, which is very difficult to do, by the way. Many times they start partially and then you end up losing the whole thing, which is unnecessary. And so again, this is where a second opinion with a TSC kidney doctor is essential to make sure it's handled correctly. And then, as I mentioned, we treat these very aggressively. For time purposes, I'm just going to mention there's recommendations on how to monitor and treat the lungs in somebody with tuberous sclerosis. There are recommendations on how to treat the heart. The most important thing here being is that everybody gets an echocardiogram the first time they're diagnosed, and then they get EKGs every 5 years for the rest of their life, just to make sure that the conduction pathways are healthy in the heart, even if the rhabdomyomas have gone away. We do have topical treatments for many of the skin manifestations. We do recommend that eye exams get done every year. We do recommend going to see the dentist, but these are not cavities, although many individuals choose to put sealants over them, which is totally fine as a treatment. And these other clinical manifestations that can occur in different parts of the body are just something that we have to pay attention to know that they exist. And if there's uncertain, there are TSC experts from around the world that they can reach out to somebody like me and say, hey, have you seen this in tuberous sclerosis before? Is it something that needs to be treated, or how would you treat this condition? And this includes things like hypertrophic limbs or other types of collections or lymphedema in these two situations as well. Tumors in the pancreas, for example. Those are rare, but we know how to treat those as well. I'm going to say one last thing and then I'll wrap up, which is we have these guidelines. These are the recommendations for medical doctors, for psychologists, psychiatrists, dietitians, educators, and how to manage tuberous sclerosis. But we know we can make the recommendations, but then if patients, A, don't know about them, that's a problem. If the doctors don't know about them, that's a problem. If the doctors know about them, but the medical system lacks the resources to make them available, that's a problem. And so this was highlighted in our last update. The TSC International, a group of parents and advocates, not doctors, actually said, okay, you gave us the guidelines, what still needs to be done from a patient perspective? And so right beside the publication for the recommendations is this second publication I can recommend to anyone and everyone, whether you're a professional or whether you're a parent or a person affected with tuberous sclerosis. Read this document, Beyond the Guidelines. It highlights some things that we need to work on still as a community of specialists and advocates on how to make this work and make it better for everybody. One is, we need health care that says we know the guidelines exist and we're going to do them. The second thing is, we need TSC experts throughout the world that can be that person who knows about tuberous sclerosis and how to treat it. And thing is, we need the healthcare systems, the governments, the hospitals, the clinics, to work together to make it so that this care is available, so that when an MRI is needed, it can be ordered and obtained. When a specialist in a specific medical specialty is needed, we can consult with them. So I will leave it there, and hopefully that's a broad place for us all to start as you start getting into much more detail about TAND, which will be exciting to hear about. Thank you.
Great, thank you, Darcy. See, I didn't think there would be anyone who would be better at doing like a whirlwind tour in half an hour, so great job, thank you. So we're now going to start switching a little bit, and as a bridge between the kind of more physical manifestations of TSC that you've heard about towards the more neuropsychiatric manifestations, I'm going to invite Annemie Toussaint to come and do the next presentation. Annemie is from the King Boudewijn Foundation. It's the Belgian Royal Foundation. And they fund a lot of research, and among the research they fund is this TANDem project that has brought us all here today. But what in particular we wanted her to come and talk about is just how they, as an organization, have worked with real people who live with rare diseases and TSC, have collaborated to come up with appropriate research agendas and appropriate research actions to meet the needs of people. So, Annemie, the floor is yours.
Good morning, everybody. I just want to say that I'm very happy to be here and to be part of this wonderful family and to feel all that positive energy here. It's really a very nice experience for me. So why am I here? As Petrus said, I'm working at the King Boudewijn Foundation in Belgium, which is a pluralistic independent foundation, and our baseline is working for a better society. How do we do that? By working on different programs in different domains and trying to support individuals and projects that make changes for the better. And one of our most important programs is the health program. I will not use a lot of slides. I think I prefer the talk, the image as well. We'll see. So in that health program, our main resources come from funds that are created by persons, individuals, families, and often because they have experienced a health problem, a health issue. And so we have like over 100 funds in various domains of pathologies, and we also manage like over 100 funds what we called funds for quality of life of patients. And fortunately, we have some funds in rare diseases. We have 9 funds focused on a specific rare disease. Then we have 3 funds focused on research on rare diseases in general. And then we have the Fund for Rare Diseases and Orphan Drugs. And that's a fund who is mainly doing advocacy and trying to have the famous Belgian plan for rare diseases implemented. And one of the members of the steering committee of that fund, it's Eva Scooters. I think you know her from the TSC Belgium organization and from Radiorg. What's the link between all this and the TANDem? Well, as you know, of course, in rare diseases, but in research in generally, there are a lot of needs and few resources. So the question is, when we have some resources, money, people, where should we put it? Where should our money and our energy go to? And that's quite a difficult question, because already in 2015, we said, okay, the research agendas mainly are set up by pharma industry, by researchers, but do they really meet the real needs of the users of the results of that research? Isn't there like a mismatch? And that was a message that was already given by a certain Professor Anna Janssen that we met professionally for other issues. And that was also the message that came out from the European RRI project, where we were involved in that, responsible research and innovation. And one of the topics was, okay, how do we set research priorities? And then we looked around and we said, okay, there are some good ideas, like the James Lind Alliance, who had a model for multi-stakeholder dialogue. We had in Amsterdam the dialogue model, We had a good example in France from the Fondation Motrice. There were quite a lot of models to set priorities in research. And we said, okay, let's do that in Belgium. And we organized a workshop in 2015, yeah, a long time ago. And that was called Priority Setting in Research by Multi-Stakeholder Dialogue. It's quite difficult to pronounce, but every word is important. What's it? A multi-stakeholder dialogue. It means that really all stakeholders, not only researchers, not only pharma, not only patients, but really everybody concerned has a voice, and there is no overruling, there are no a prioris. Everybody is at the same level, and everybody is open to listen and invited to listen to the others without any prerogative. It seems easy, but it isn't. There is not such as the one unique, perfect model. You always have to adapt on the people that are there and on the topic. That's something we had to learn afterwards too. But we had that first workshop, and we said, okay, we will work on this model, but if some good pilot projects come out, we offer you a kind of methodological help, and if a good research question should come out, we will try to find financing to do that research. And at the end of that workshop, 3 pilot projects were proposed, and one of them was proposed by Anna Janssen, and she said, let's do some priority setting on TSC. We said, okay, and that was the start of a long journey, a very, very interesting journey on TSC priority setting. It took us like 1.5 years to do all the process. We started with literature study, analysis. Then, no, we started with making a project team, very important. Then we did a lot of literature study. And then we went to the patients, and we had a lot of individual interviews and also focus groups. And I must say that focus groups, I even remember every moment of these meetings, because I was so impressed by the stories of the families and of the patients. It was really like a new world for me, and well, I never forget that. And then we also interviewed a lot of experts, or sorry, so-called experts, because we had fantastic clinicians and researchers. But we also met a doctor who said, I'm a specialist in TSC, and he had met one single person in all his life. So he said, okay, expertise. But anyway, in the group of the patients and in the group of the experts, patients are experts too, sorry, in the group of the professionals, we had a lot of questions and needs. And the first thing we had to do was translate it in a researchable question. A need is not necessarily something you can do research on. So we had those researchable questions, and then came the very important moment. We put all these people together and all these researchable questions on the table on a workshop in Brussels, and we said, okay, we had different groups, very mixed. Here you have all these questions. You got coins, TSC coins, and you have to decide where are you going to put your money. One question, all the money there, or just one coin for every question. Okay, and it took us like 1 long day, and you could feel the energy, and people were working there. It was really fantastic. But we ended up with a list of researchable questions, and everybody in the room at the end said, I'm fine with that. Okay, I feel like what I wanted to see there is there. So that was very important, that everybody went home, okay, relax, we are doing a good job, and my needs are there. And then we promised, if there is a good research question, we will try to help you to finance it. And the second thing we did was, we had that list of research questions, okay. Then we had the publication with main author Anna Janssen on how do you set up multi-stakeholder dialogue in the TSC. And then we also had a list of needs of patients that were not necessarily research questions, but we thought it was very important to give the attention to that package too. And then on one of the first topics on the research list was the TAND. And so we said, okay, we have to try to finance that research on TAND, because it's like the most important struggle for patients and clinicians. And so we went to the founders of the fund Tournai de Buisson, who said, okay, we want to finance research in rare diseases, but we don't know nothing about it. And we explained what was the importance of the TSC research. And they said, okay, let's go for that. And that's where started the whole TANDem project that's now ongoing for more than 3 years. And we are really very happy with all the advancements of the project. We are looking forward to see the end of the project. I must say that we did some other priority setting exercises, like in diabetes, we did it in neurodegenerative diseases, we did it in hepatology and biobanks, we did it in working capacity. And every experience was, as I said, a little bit different. You really have to see, okay, what is the main issue? Who do we have around the table? And I must say, for us, the TSC experience is really like the mother project. It's the one who has the most beautiful outcomes in terms of dialoguing with people, in terms of co-creation, in terms of reporting on a level that everybody is capable to understand, in terms of impact driven. So it's really kind of a model project, I must say. And so that's why we are so happy that we were able to help this make happen.
So before Annemie embarrasses us anymore, I'm going to invite Anna Janssen to tell you about TAN, the TANDem project, for the next 15 or 20 minutes. And Dave.
Good. Thank you, Annemie. Just sitting there and listening again and thinking back how the whole story came about. I was just thinking like how sometimes coincidences lead to such strange and hopefully impactful things in life. So yeah, that was definitely a good meeting. I am going to focus more on TSC-associated neuropsychiatric disorders globally, and on the TANDem project more specifically. And I will present this really on behalf of the entire TAND Consortium, who will have heard these things before. So the keywords of my talk and the order of what I'm going to discuss is first something brief about the terminology, TSC-associated neuropsychiatric disorders, and why we thought that this was an important acronym or terminology to pick. Then something on the TAND checklist, something about TAND clusters, just to make sure you're aligned with all the terminology, which sometimes even for us can be challenging, and then the TANDem project. So there we go. Why TAND? And this brings us back to a long time ago, 2005, when a group of individuals, one of the culprits in the room, developed guidelines or recommendations for the assessment of the so-called cognitive and behavioral problems in tuberous sclerosis. And then, when 5 years later, an evaluation was done, and that was done in the UK, but I think it would have given similar results all over the world, globally. It was clear that approximately everyone with TSC would have some biopsychosocial difficulties over the span of their lifetime. But less than 20% received appropriate evaluation and or guidance. So that really uncovered a huge assessment and treatment gap. And that's, I think, a very sobering observation. So another difficulty that we were facing is the multidimensional nature of these difficulties, and also the fact that it was very difficult to find a common language, to speak and to use the same terminologies. Because what I learned was that, for example, when people in the UK talk about learning difficulties, they mean intellectual disability. When I talk about learning difficulties, I think about something else. It's just one example of when you write papers and you look at research and you want to compare things, it's very difficult because we don't speak the same language. So that was also a big challenge. So then when similar and more elaborate group of people met in 2012 as part of that the recommendations guideline movement, the psychiatry panel was facing these difficulties. Like, what can we do to make sure that we can change this? And so that's the two ideas we came up with at that moment, was on the one hand to try to introduce a common terminology so that we could put these neuropsychiatric difficulties that are associated with TSC on the map, next to all the physical difficulties, kidneys, epilepsy, SEGA, but also just to have something specific that when you check as a clinician, like, did I pay attention to everything? That you don't forget to tick the box for TAND, because very often it was just not addressed. And then another proposal was, how can we help clinicians to make sure that they are systematic in their questioning? And that helped me a lot also in my clinical practice, to have a systematic approach to all these different bits and pieces. And I found it also very difficult to know, like, then how can we separate like behaviors, and then you have a psychiatric diagnosis such as autism, and so how can we organize that? And this is why the TAND checklist was developed, and it really served as an interview guide for healthcare professionals to have a conversation with a family, and to structure that interview and make sure that at the end of the interview we had everything on the radar, and that we could help families also to find priorities, like if we can choose one thing to work on first, then what would that be? And it was really helpful going through this conversation to set goals just one time to the next, to move on. So these are the different levels according to how the concept is organized. And so TAND is really an umbrella term for different levels, behaviors, neuropsychiatric diagnoses such as autism, ADHD, intellectual ability of individuals and how that relates to how they can function and adapt in daily life, an academic level, how things are going in school and professionally. There is a neuropsychological level that looks at specific brain skills, such as memory or concentration. And then, very importantly, there is a psychosocial level, the impact of living with TSC on self-esteem, or on your relationship with your siblings, or with your parents, or with your colleagues. So that's the way we try to organize the umbrella and the checklist. And then, when this was being used, it was clear that looking at each individual, they had very different TAND profiles. And then thinking about what can we do, like how can we help individuals with TSC and these specific profiles, it felt very overwhelming because every profile was very different. And so if as a therapist you have to make a treatment plan and you have to really tailor it for every individual person, we will feel like, we cannot do this. And so this is what Petrus and Lauren called a treatment paralysis. You send someone to the therapist and they say, I don't know anything about TSC and not about this profile. I've never seen anything and I can't do anything. So they will send the people back. And so it's going back and forth and nothing happens. And then Lauren Leclésio, who did her PhD work on this, she reshuffled these profiles and she put them together and thought like, but maybe some of them look a bit similar. And then she had the, I think, great idea to see if we could simplify these profiles, and if by using data clustering methods, we could look at what behavior or what feature clusters with another one naturally. Like if you have one, what is very likely to occur in addition. And so by applying data clustering methods, she was able to identify, and through different cohorts it has been validated, 7 natural TAND clusters. And when that comes back to us clinicians, we say, there is an autism-like cluster. We know something about that. There is an overactivity and impulsivity cluster, and then we think like people like Robert, and we think, okay, Robert, then what can we do about that? There is a scholastic cluster. And people know much more about dyslexia, dyscalculia. If you talk that to teachers, they will say, it's not TSC, it's dyslexia. I can deal with that, that's fine, bring it on. So this is easier. It's much more understandable for clinicians, but also for therapists. So this is a level of simplifying these unique profiles into more simpler and, clusters that we do know things about. So this is really the instrumental work of Lauren Leclésio. So then she went back to the community and asked like, okay, is there anything more that we should be doing, or have we met our goals? So no, journey is far from finished. We would like to be less dependent on this interview with the clinicians because they're hard to get and they don't have much time, and so they don't always have the time to sit through the interview. And sometimes they just hand out a checklist and say, can you please fill it? And they put it in the file and nothing happens. So they said, we want it ourselves, in our hands, so that we can complete it ourselves. But then also, from clinical experience, we felt that when you just give it to families and they sit on their own and complete it, and you can then not have a conversation about the results, it's not good clinical practice. You signal a problem, and nobody talks to you about it. So that's not appropriate. Then I think you can better not ask. They also said we don't want it only on paper, but we want it on our smartphone so that we can just have it with us and it's easily accessible. We can store it, we can keep it. And they also asked for a toolkit in the sense that there could be recommendations or advice or tips to already implement themselves while waiting for expert assessment and specific therapies, but just what can we do ourselves to be empowered? So these were really the foundations of the TANDem project. I need to speed up. So coincidentally, that's about the time that we had done the priority setting exercise, and so we were very grateful to have the funding to get this going. And I just want to highlight that where are we now? The timeline's on the left. So we got the stakeholders together, we had a launch meeting 3 years ago, the project that you see on the right has been turning in the meantime, and now we're here for our multi-stakeholder review meeting to prepare for the last year, and beyond. So this is all the project in detail that has been published, and you can find that freely online. I just want to highlight that it's an international multi-stakeholder participatory research project. The international is illustrated here, and so indeed different countries. And participatory means that the lived experts are in the tissue of the consortium. They're everywhere, and they really serve as our navigator to make sure that the project moves in the right direction. So what have we done so far? The first aim was to develop the TAND-SQ. And so this is a figure that was drawn by Tosca, and it just shows how we moved from the TAND checklist that will look at lifetime, have you ever had this difficulty, through an iterative process with the consortium and with families. We have adjusted a couple of questions, we've added a number of questions, we've reviewed it, also added a bit on strengths, and this is now the final version of the TAND-SQ. We have it on paper, and it also has been implemented in the app, so the app is done, it's live, and data collection has just started. And it's very easy to say just in 1 minute with one slide, but it has been a huge journey, especially not so much from the technical side also, but also because of regulations, what all the regulations imply when you want to collect sensitive data from families and individuals through an app. So we've learned a lot there. So the checklist, check. We will further validate it against formal assessments, but that's still to come. Then the second aim is the TAND toolkit, and there's 3 things that we did to form the basis for this toolkit. The first thing we did was the consortium split up in little groups with for each cluster, with a cluster lead, and each group dove into the literature to see what is there on this cluster, what evidence do we have for interventions and treatment, specifically in TSC, and if we don't find much for TSC, then what can we use from the overactive, impulsive cluster outside of TSC, or for autism not related to TSC, and what can we use from these advices for our community? So that has been written down in chapters with recommendations at the end. And then in parallel, a scoping review had been done with the aim to just do a state-of-the-art, bird's eye view of the research landscape in TSC, in TAND. What do we know now? What has been done so far? What is there? But especially, where are the gaps? What do we need to look into more closely in future? And so I'm not going to go into detail here, but we have identified a number of gaps that need our attention for the future. And this also has been published now and is accessible, it's open accessible. And then the third action is our consensus building process. So drawing on these 2 previous exercises, and again, through a whole process of consensus building, we came up with per cluster all the recommendations, but then we realized that there are a number of recommendations that are really relevant for each cluster, for every aspect of TAND. And so these have been brought together, and they are at the heart of the consensus recommendations. These are the 10 core principles, and around that we have specific recommendations per cluster. So cluster-specific recommendations. And then around that, that's the outer circle, these are the psychosocial recommendations, what to do to support and to live with TSC. And so, can I quickly go through them? I'm almost at the end. I just want to go through the 10 principal recommendations. I think it came out of the whole exercise, and I just want to see how they resonate with you. So everyone with TSC is at risk of TAND. That is number 1 for also clinicians and people in the field to realize, to have it on the map. It at risk. It doesn't mean will be a problem, but be attentive to it and talk about it. Everyone with TSC needs lifelong monitoring for the emergence of TAND. Screen at least once a year, And don't just screen. In the top, there is screen, act, repeat. So you screen, but do something or try to do something about it. And don't just put it away. Screen, act, and then reevaluate. Have we achieved our goal or do we need to go back? The goal is early identification and early intervention. The sooner, the better. Number 5, TAND clusters cluster together. If you have difficulties in one cluster, you should be alarmed and carefully check for the others. Are there difficulties also at other levels? Always consider the impact of physical health problems and medication for physical health problems, such as anti-seizure meds, for example, on TAND. Work with families as lived experts in TSC and TAND. We learn from you. Generate a biopsychosocial whole system plan for intervention. Just not jump into one aspect, but try to be holistic. Be evidence-based and evidence-informed. And strive for optimal functional outcome and quality of life throughout the journey with TSC and TAND. We cannot just make it go away, but how can we try to make it as livable as possible? So with all that, the toolkit has been developed. Each cluster made their own toolkit proposal, and so it will now be integrated into the app. It will consist of an introductory video where families will first learn something about that specific cluster, for example, the autism-like cluster. What is that about? When would I need to think or maybe worry about it? And then what can I do? What should we seek? What advice or what action should we seek? What should we look out for? And what can we do ourselves? That will be the structure of this toolkit. Next steps, and then I'm done. So the TAND SQ final version has now been finished, and it is tomorrow. We hope to check off the final version of the publication, and then we can send it in for publication, so we can submit it. Same for the consensus recommendations. We also just want to make sure that all the work that went into these chapters can be made available to the community as well. As I told you, the TAND SQ will be also validated against formal neuropsychiatric assessments. We will also validate the toolkit with the community to see if it meets your expectations or if we need to change it or make it different. And very importantly for the next year, we want to think about the road to scaling up and scaling out. How can we make sure that when the app goes live, it can be available to the wider community? Is it appropriate also for other cultures, other languages? Can we do something for other neurogenetic syndromes, for example? There's lots of questions that are still on the table and that we will need to address as we go forward. So we will also think about when the app collects data and these data come in, how can we use them to better inform us about improving TAND? What can we learn from that, also to inform our practice? And with that, I will thank you for your attention.
Great, thank you, Anne. Now, we're going to go into a rapid fire. And I'm going to be even tougher with the speakers. So we're going to have 7 very short presentations, or 8, because we're now going to ask each of the cluster leads, you've heard about the clusters, just to come and introduce the cluster and say something about each of those clusters to you. And then we'll end with a wraparound, and hopefully by then we'll have time for tea and some fresh air. So, without further ado, I'm going to get David to set you up. And team, are you ready? I will give each of you a 1-minute warning.
Good morning, everybody. My name is Nola Chambers. I'm a speech and language therapist from Cape Town, and I'm going to very briefly tell you about the autism-like cluster. When we talk about this cluster, we're really talking about behaviors in 2 different areas. So in the social communication area, we're talking about things like an absence or a delay in learning language, in learning to talk. It's also things like having poor eye contact, especially when communicating or trying to communicate. And also things like difficulty getting on with your peers. And then on the other side, in the other sort of domain, it's more unusual or repetitive use of behavior. So like unusual use of language, repeating words and phrases over and over again, or repetitive use of your body in unusual movements, or with objects like spinning the wheels of a car. It also includes things like rigid or inflexible, being rigid and inflexible in your daily routines, wanting to do things the same way every time, and sensory differences like sensory seeking behaviors or sensory avoiding behaviors. Those are the behaviors that are listed on the checklist that Anne just mentioned, and there are also some precursors to these behaviors, like lack of response to name in young infants, less social babbling, and less coordination of gaze and gestures in the developing toddler, as well as lack of imaginative play. Now, there's been actually quite a lot of research into these autism-like behaviors in TSC, and what it's found is that the rates of these behaviors is actually quite high, and that the rates increase when there is also intellectual disability and seizures. But these things don't have to be present for individuals to experience some autism-like cluster behaviors. They can often be detected very early on, as you saw in the previous slide, and they can endure into adulthood and really have an impact on quality of life. And on this last point, I would like to say that depending on the nature of these difficulties, the child or the individual may also meet criteria for an additional clinical diagnosis of autism, which can be very tough for families to consider. But if it can help you access additional supports, then and help you understand the pattern of behaviors, it can be very beneficial. So what we recommend that you seek is an evaluation for any communication differences or delays that you might observe, and any developmental specialist is in a good position to help you with this, like a pediatrician or a speech-language therapist, occupational therapist or psychologist, and let them help you develop an intervention plan for addressing some of these difficulties. And if you are concerned about autism, we encourage you to seek an evaluation for autism with someone who has some autism expertise, usually a psychologist or a child psychiatrist or a developmental neurologist. And if you get a diagnosis of autism, then to encourage you to access autism-specific supports and interventions. And in South Africa, often that translates also to appropriate school placement, a question that parents have to get onto the journey very early. And then what can you do? And these are some of the things that we're going to put into the toolkit. We recommend that you start early and monitor your child's development. And there are some wonderful free resources that families can use to monitor development. The Centers for Disease Control have wonderful developmental checklists online and a monitoring app that you can use. And there's another organization, Baby Navigator, that also offers screening tools and monthly checklists that parents can use to monitor their child's development. If you are noticing some of these developmental delays, we recommend that you implement some strategies at home that are consistent with naturalistic developmental behavioral interventions, which is a huge mouthful. We call them NDBIs for short. And there again are some free materials that you can access that are consistent with these types of interventions. And I think my 5 minutes is up. Thank you.
Alrighty. So I'm Dr. Gibson. I've traveled here from Memphis, Tennessee in the U.S. I direct a tuberous sclerosis, a TAND clinic in the U.S. I see children and adults with TAND every week. And so I'm going to talk to you about the dysregulated behavior cluster. So what does it include? It includes aggression, which is injury of another person, and then self-injury, which is injury of oneself, and then also temper tantrums, so kind of these complete meltdowns. The key thing to remember in TAND, and probably in other disorders as well, is that there's a spectrum of ages and severity. So tantrums, I have 30-year-olds who have tantrums. So it can happen across the age spectrum and also different levels of severity. So for some people, it's very mild. A child has, a meltdown in a store, and you pick them up and you get them going. But then some adults kick out car shield windows and can hurt people with sharp objects. So there's definitely a range of severity. There isn't a cure, but there are treatment options. So what to seek? Medical evaluation first, because there can be, especially in TSC, an underlying medical issue that needs to be addressed that's not simply behavioral. Second thing to seek, which would be a functional behavioral assessment. And so what is that? That's looking at the behavior with a professional to see kind of what happens before the behavior, what is the behavior, and then what's the consequence of that. We call it the ABCs, the antecedent, the behavior, the consequence. And that's really important because the behavior oftentimes is a method of communication. So for some people, they might have a temper tantrum because they want to escape a specific task. And so if you figure out what the function is, then you can target that in treatment. And then if medication management is, an option, it's not the only option, but doing that with a professional. So oftentimes I love social media, but sometimes people will go to social media and say, oh, Dr. Gibson told this person to use this medicine, so I'm going to use this medicine for that reason. And that's just not the way to go. So because it should be managed by a professional. So then what to do? Key, prevent as much as possible. So knowing those triggers, knowing what happens, seeing what we can do to kind of eliminate the things that would lead up to the behavior. And then parent training, making sure that parents or caregivers feel equipped to address the behavior in an appropriate way. Behavioral intervention, so I always say that that's the foundation. There's a lot of other things that we can do, but what are those behavioral interventions that are needed for that behavior? Oftentimes it takes a long time to establish those. They aren't quick, but they're effective, and they can be lifelong. And then academic intervention. For a lot of individuals, especially those having these behaviors, a lot of times these behaviors can come up in a school setting. So figuring out how are we going to address that in a school setting. And then the final thing that's not on my slide, and I came all the way across the world just to tell you guys this, no matter what, the severity of the behavior, how long it's been going on, what's happening, just remembering that there's hope. There's a path forward. It's not the same for everybody. It's not simple, and it's not quick, but there is hope. Thank you.
Hi everyone, my name is Dr. Stacey Bissell. I'm a behavioural researcher in neurodevelopmental disorders based at the University of Birmingham in the UK. So I'm here to talk to you about the Eat and Sleep cluster. And there's a lot of detail on my slides, so don't worry about that. If you want to take pictures, you can. It's just at the core of the Eat Sleep cluster, there may be TSC-specific biological mechanisms because of the role of the mTOR pathway and the processes that it's involved in terms of eat and sleep behaviour. And also at the core, I would say, we don't know enough about eat and sleep and behaviour in TSC compared to some of the other clusters. So there's quite an established intellectual disability literature or autism literature that is pretty well advanced. I would say eat and sleep and behaviour is in its infancy in what we know and what's published. So it's the most under-researched of the TAND clusters. So there is a link between eat and sleep and behaviour as these underlying biological mechanisms, but the recommendations that we have in our toolkit are very separate for eating and sleep and behaviour. There is some crossover in terms of appetite and how that affects sleep and behaviour and vice versa. But our recommendations are very different for both. So I would encourage you at the roundtable discussions to come and talk to me, because the profile of eating behaviour isn't well established. So I'm really keen to hear about your experiences with your children or your own experiences in terms of eating behaviour. But we think because of the association with autism, what we're looking out for are things like selective food preferences, fussy eating, regurgitation. And then in terms of sleep difficulties, it's the second most common behavioural presentation of TAND, yet we really don't know much about the profile. It's quite variable. So some things that we think we're looking for are a shorter overall sleep duration, night wake-ins, and this fragmented pattern of sleep. So we might see some nocturnal seizures and early morning wake-in. So I've parsed out the eating behaviour and the sleep behaviour, what to seek information. First and foremost, we can all experience difficulties with poor appetite or poor sleep, but to receive a medical diagnosis, you would need to seek support from a health professional. So be cautious of any changes in weight or appetite, and first and foremost, rule out underlying pain that may be associated with a change in weight or appetite. So this may mean revisiting the medication profile and the amount of medication for anti-epileptic medication, for example. At the core, healthy eating behaviour plans are available to everyone, and that a healthy diet should be at the core of what you're trying to obtain. Again, a sleep disorder diagnosis, so something like insomnia or restless leg syndrome, that's pretty difficult to self-diagnose, so you would need to seek medical support for a diagnosed sleep disorder. But again, any sudden changes in sleep quality or quantity, consider pain or consider side effects of any medications. For adults with TSC, seek additional support and medical advice around medication aids and melatonin for sleep, but also consider the mental health effects of poor sleep. So we know that all of the clusters cluster together, but more so than any of them, we know that sleep is affected by depression, anxiety, for example. And so what to do, so feel free to take a picture of this. I'm not going to go into much detail, but just to say that there are good recommendations out there for the general literature, the autism literature, the intellectual disability literature, which we've taken resources from, but we've separated them out because the recommendations for sleep and eating behaviour will vary depending on age. So things like napping, for example, for toddlers, and when to wean out napping, that's not really appropriate when we're thinking about adult sleep, for example. So for eating behaviour, things like keeping food diaries, the ABC charts that Tanja has talked about, food chain and behavioural reinforcement, those are all in the toolkits. Guidance for teenagers and adults, mostly keeping food diaries, but also having a conducive sleeping environment. Bedtime routines, sleep hygiene recommendations, keeping sleep diaries, behavioural reinforcement strategies, and we've also got different guidance for teenagers and adults in the toolkit. So there's a lot to unpack, so I'm going to stop there. Thank you.
People don't know who's next.
I'm Agnies van Egen. I think you're the only country in the world who may be able to pronounce my name. So I'm going to say it this way. I'm from Amsterdam and I run a TAND clinic on Mondays, and that's why I'm here to talk about mood and anxiety disorders. Just like the eating and sleeping disorders, they're under researched, I think partly because we're not sure if really the biological mechanism of TSC predisposes specifically for mood and anxiety disorders, but we know because there's so many physical problems and also other TAND comorbidities comorbidities, that they may be especially vulnerable. We know also in other patients with other genetic syndromes that they're also more vulnerable. And they deserve attention because they can be very treatable and preventable. So that's why it's important to give special attention to this. Let's see where I can do. What do I use? The arrow, it's not working. Oh, this arrow here. Great. So we are giving some recommendations, and because many people suffer mood and anxiety disorders, they deserve also the same monitoring as other TAND difficulties. It seems like these difficulties emerge over time. So in young children, you usually don't see like really mood disorders or depression, but you can see some anxieties like separation anxieties or phobia, specific anxieties. But in teenage years and adolescence, you see these numbers go up, and that's usually because people are realizing they're different, maybe not being successful in daily life, successful at school, or successful in social relationships, and that's why they will maybe have failure experiences, and anxieties may increase, but also feelings of low mood, feeling not as worthy as the rest of their peers. So that's when you see these anxiety disorders and mood disorders appear. Also, which we don't mention on the slide specifically, but also trauma disorders, having very life events or being bullied at school also happens a lot in these individuals. And of course, this may cause anxiety and mood disorders as well. So it's very important also to look out for that. So they're underdiagnosed and undertreated. So again, just like with other TAND difficulties, with any change in behavior, think of mood and anxiety disorders. It can be like we call externalizing behavior, like challenging behavioral, like Tangela talked about, but also the withdrawn behavior, and that's maybe not so noticeable, and maybe sometimes even people like it if people are a little bit withdrawn or have less energy, but just keep in mind it can also be anxiety or depression. Of course, there are many good physical problems that people have. Mood and anxiety disorders can also mimic side effects of anti-epileptic drugs. Also, mTOR inhibitors can make you more tired. So sometimes it's attributed to the epilepsy, to the medication used for epilepsy or the tumor growth. So just always think of this. But also think of pain and discomfort. People can show it with anxiety or being withdrawn. So always think also of, especially in people who cannot communicate their symptoms very well. There's no evidence really in TEC about specific medication or other therapies used for these disorders. So we use the general guidelines. And again, these are among the most treatable disorders in for any psychiatric condition. So that's much more treatable than autistic symptoms, which we cannot treat very well, like ADHD. And this is something, if you treat it, it may disappear forever. So it's really an investment in the future to really go about this quite aggressively. It's complex, but it really helps very well. And also, you can do this in different ways. Of course, the context is very important. You saw the very complex profiles that Anna Janssen showed, and it's very important to have this profile for everybody to see where we can accommodate people to make living as easy as possible, because we know if stress goes down, mood goes up, people are more comfortable, and then they're able to learn and develop better. So it's very important to make the environment adjusted to the person. If that's not enough, of course, there are many therapies, cognitive behavioral therapies, but also nonverbal therapies can be very helpful, EMDR, the trauma therapies, and of course, helping the parents deal with this as well. Lastly, if this is not enough, we have medication. The medication can help a little bit, but it's not hugely effective, but we have antidepressants, which also can help with anxieties, and also other drugs which may help, especially in the beginning, to get people more susceptible to other types of treatments. Lastly, I think we need lots and lots more research, which people will develop the disorders and how can we prevent this. I think this monitoring and really asking in the consultation room is the most important, and getting to know your child and your patients over life, how they show symptoms and also what it's a manifestation of, and that will help us be aware and treat this and prevent this in the future. So I hope I made it within 5 minutes.
Hello everyone, I'm Jennifer Flynn and I'm a vice principal from Canada. I'm going to actually speak to the neuropsychological cluster, which is Dr. Anna Byers, who leads this particular cluster, but she couldn't be with us, so I'm just going to share some of her information. So when we're talking about the neuropsychological cluster, we're talking about a lot of different aspects that can overlap, as you can see from this diagram. So a lot of different skills that can overlap and that can be difficult for people with TSC. So we have language, we have visual spatial skills, memory, motor, something we call motor integration, sensory issues, problem solving, and executive functioning. So that kind of planning aspect when we're thinking about our what we're going to do and consequences and things like that. So there's a lot of different aspects to the neuropsychological cluster. And when we're thinking about what to seek, so the first thing is we want to look at getting some evaluation done, and again, earlier is better. So looking at infants and toddlers, if there's an opportunity for some developmental evaluation from a psychologist or a neuropsychologist, a speech evaluation. Early intervention really is important when we're thinking about really everything, but the neuropsychological cluster, we really want to think early if possible. And then as children move into school age, thinking about neuropsychological evaluations, sometimes they can be done through the school, sometimes separate from the school. And then for adults, neuropsychological evaluation again is also very important. So for most of these, you're going to probably start with your primary care provider, either to get a referral or to get some evaluation done. So that's a good place to start. And then if you're looking for more information, the TS Alliance and lots of other associations, TSCI, they can all give you some information as well. So as an example for what you might seek, Anne has included this image here that talks about the importance of things like music, singing, and dancing. So we're thinking about neuropsychological development, focusing on something as simple as music, so learning to play an instrument can really help with that selective attention and monitoring, the physical skills. All of that together can work to improve working memory. And then, you know, learning to participate in music classes, so some children even just enjoy sort of listening to music or being part of those classes. Again, it can promote that working memory development and a lot of those other skills. Singing different songs in parts or in rounds, again, kind of that coordination of skills, and dancing too, because now you're coordinating that physical movement along with the working memory movement. So those are just some little tips that you can focus on to help develop your neuropsychological skills.
So hello, I'm Robert Waltereit from Göttingen in Germany. I'm a both child and adolescent as well as adult psychiatrist, and I would like to tell you something about the overactive impulsive cluster. What is the overactive impulsive cluster? We have three main symptoms: overactivity, restlessness, and impulsivity. Well, what is overactivity? All right, we'll come to that on the next slide. Overactivity, restlessness, and impulsivity are very common in tuberous sclerosis. We find it in, oops, can you hear me? Yeah. We find it in very many people with TSC, but also in people who do not have a TSC. These symptoms can be pretty common, and they are very often found in the disorder ADHD, attention deficit hyperactivity disorder. Although you can have symptoms of overactivity and impulsivity in TSC without having ADHD, very often the explanation for overactivity and impulsivity in people with TSC is that they do have ADHD. And that is, well, you may think, so I have an additional disorder, but that is also a very good, but it also has very many advantages, because ADHD is a very well-studied disorder, and there are very good treatment options. Well, so I see my slides are very much verbal. So overactivity basically means that that's the type of behavior you find in many children. Of course, many children are overactive naturally, but if you have very much overactivity, much more overactivity, then there is a usual, depending on the age of the child, then overactivity is a problem. The same is the case for impulsivity, and the same is the case for impulsivity. Everyone, of course, can be impulsive, but if you are much more impulsive, then it is normal. Then impulsivity is a problem by itself. What to seek and what to do. Well, the idea is when you have problems from the overactivity and impulsivity cluster, first thing is to get to know more about this from other people who have the same problems. Then it is a very good idea to get a professional assessment by a mental health care provider, including those ones who can do an assessment of ADHD. As I just said, is a typical problem when you have problems from this cluster. Then often, especially when there is ADHD, it is helpful to have an evaluation for professional help, often including medication. But it's also a very good idea to evaluate non-medical strategies, for example, self-management strategies. Thank you very much.
Thank you. So my name is Chris Kingswood. So as an adult kidney specialist, this cluster is so far out of my comfort zone. You might wonder why I asked, but I'm also a parent of an adult daughter with tuberous sclerosis. So my wife and I live this every day. Button, it's up there. Yeah. So as we've seen this before, the various aspects of TAND, the psychosocial cluster sort of wraps around and integrates and affects all the other aspects of TAND. And we divided it into 5 different broad categories. Self-esteem for the person with tuberous sclerosis and their family, stress amongst the person and their family, support, family relationships, and well-being and quality of life. What to know? So first thing is that these difficulties are not only very common, probably almost universal in families with TSC, and can include many things. I won't go all of these things. I'll press an OK, go away. That's, but just is to broadly highlight them, that there's psychiatric problems, psychological problems, low self-esteem, negative feelings towards yourself, and it ramps up the sort of the burden of illness unless you address these. So what to seek? There are services that can be looked for. I mean, like all aspects of TAND, there's no universal, complete answer. The problem is that this is a very under-researched and under-treated field, and the TAND app is just the beginning of getting to grips with that. But there are, once you start looking, there are family, community psychiatric services, psychological support services, support at school, and it's well worth seeking that out actively and keeping on going. And getting professional help for the person with TSC and for their family. And it's best not to forget the people who are being affected by the stress within the family, because the carers need care. Otherwise they can't care for the person they're caring for. So, go on to the next. Just 3 very quick slides, which I'm not going to go into detail. This just gives you a flavour of what's in the app, and this is how it's laid out and how you'll see it. And you can see in the stress app, there's a lead into it and a definition of what the stress is. There's, again, what is stress and how to start dealing with it, and what's the broader aspects, and in this case the last box of what is family stress, and then what to do. And with that I'll hand back to Jennifer.
Thank you. So I'm going to speak about the scholastic cluster. Feeling very short. Okay, so so just to start off with, most people with TSC have some sort of difficulty in school, and this can look very different because, of course, every individual with TSC is so different. But really, it's pretty universal to say that everybody with TSC is going to have some kind of difficulty with some aspect of schooling. And there's lots of reasons for this. It could be because of an intellectual disability. It could be that the person has average intellectual skills but has a specific difficulty with reading or math or some other academic area. And then there's all the other aspects of TAND that can really impact your ability to do schooling as well, like ADHD, behavior challenges, working memory, social issues. I know someone mentioned bullying earlier, and certainly, you know, all of those social issues can cause difficulties in school. Oh, I did not touch anything, I swear.
But it's plugged in.
Oh.
Okay. All right. So what to seek? So the first piece is, of course, there are lots of different models of education, and around the world education looks very different in different settings. So first of all, to think about, you know, what kind of settings are available where you live. So in some places there are more inclusive settings where children with all different types of abilities are together in one classroom with varying levels of support. Sometimes there's more specialized classroom placements, and sometimes there's even specialized school placements. So really the first step is to find out what's available in your area, and then to figure out what best meets the needs of your particular child, because that really does look different for everyone. And you know, an inclusive setting for one child might be the best, but for another child a more specialized setting might be more beneficial. So it's really to think about what's available and what's going to work for you and for your child. And then to find out about assessments that might help plan for your child. So in some settings, there are psychologists that work with schools and can do an assessment with the school. In other settings, this might be more through your primary care physician to get some assessments done to help the educators to know, well, what kinds of skills maybe do we need to work on? What kinds of accommodations can we put in place to support your child? And then we look at what to do. So the first thing is, and I always say this because, you know, as a teacher, read to and with your child early and often. And it sounds like such a simple thing, but regardless of intellectual level, reading to and with your child, it really is essential. Embedding math into everyday activities, silly things like we're setting the table, you know, how many forks do we need, those kinds of things, just those discussions that build on some early numeracy skills. And again, as I mentioned earlier, considering placements for your child, and then really seek out a meeting with your educational team. So whatever type of placement you're in, asking for a meeting that could be with maybe the teacher, maybe the resource teacher or special education teacher as well, maybe if there's an educational assistant involved, and then bring in the vice principal or the principal, because they can really be a support, and if they know what's happening and what the needs are in the class, then they can kind of help with that follow-through piece as well. And a really important thing is developing an individual education plan. That's often in many parts of the world called an IEP. And that's really where you're looking at what are the very specific needs of your particular child and how can those be accommodated in school. And so sometimes it's things like accommodations, as in maybe the child does best if they sit close to the front, or maybe they do better with an oral assessment rather than having to write it out. And it can be all the way to modifying the curriculum completely. So the child maybe is not going to be successful with the regular, maybe math curriculum, but we could modify that to give them some goals that would be attainable. And then, of course, seeking early and ongoing screening for scholastic difficulties and followed up by appropriate actions. So if we're noticing a difficulty here, what do we need to do about it? And then the last thing I wanted to mention was to think about transitions, and I realize that's really small to see, but thinking about transitions when you're thinking about the schooling system and to consider them early. So I just made a little chart here that shows, you know, the student, the parent, the school, and community agencies. So it's just some things to consider. You know, how you can prepare your child for their transitions through schooling from primary school, middle school, high school, and beyond. And that's it. Thank you.
Great. Well, that wraps up, almost on time, the formal part of our assessment, of our morning. I'm going to ask that we turn on the lights, because this is the point we're going to say goodbye to everyone on the live stream and on the recording. We're all going to have a chance to wake up in the room. And I'm just quickly going to tell you what's going to happen after the break, just so that you're all prepared and you can take your time. So before I do that, please just join me once more in thanking everyone for their rapid presentations and in-depth presentations this morning. I hope that all your brains are feeling quite full but stimulated now. Because how we've planned it is that we're going to have a tea break, and then after the tea or coffee break, we're going to move to the room next door. The room next door has lots of round tables, because I said we're going to have a round table discussion. So you'll remember that when you registered, we asked you what in particular would you be interested to talk about. And so there were three very clear themes that emerged. So we're going to have 3 tables. And I'm going to ask some of our consortium members to sit at each table. You will then have the choice of going to sit at each of those 3 tables in turn to chat to people, to ask specific questions, to talk about things as you want. And then we'll spend about an hour doing that. And at the end, we're going to come back in the room and just hear from the 3 main groups what the discussions were, etc. After that, we're going to have lunch together. So if you have very particular or personal questions you might want to ask one of the team, that would probably be the best time to grab somebody rather than to want to ask a very personal question in a round table setting. But that's also why I wanted you to meet many of the teams, and they can tell you who to talk to about particular kinds of questions. So, here are the three main themes that came from you. The first theme was around education and educational support. We have a number of educational psychologists, we have families here. So Jen, our vice principal from Canada, will lead the education table, so that'll be one of the tables that you can go to. The second main theme that came up is there were lots of questions about medications. Not just about everolimus, but about drugs. So I'm going to ask Darcy and Robert and Chris Kingswood to lead a medication table. So if you want to go to the medication table and ask about meds. And the third theme that came out is many of you were very keen to talk about setting up a South African parent organization or TSC organization. And so that's going to be the third theme. And I'm going to ask Katie from the TSC Alliance in the USA, and Shoba, who helped set up an Indian organization, and Megumi, who helped to set up and runs a Japanese organization, to lead those tables so that our families, and doctors and anyone else, can chat and come up with ideas together. Those are the three main tables. If you feel you're being shortchanged and your burning question is not on that list, come and talk to me. We'll make sure we let you talk to the right people. But that's the plan for us after the coffee break and tea break. Let's get some fresh air, coffee, and we'll start at past. Thank you, everyone.